we have two types of nervous system, so to speak. We have what's called the sympathetic nervous system, which is your fight or flight system. You see a bear in the room with you, your body goes full sympathetic. We got to run away from the bear. And it's the opposite of the parasympathetic system, which is we call it the rest and digest system. And so patients with dysautonomia, they're going to have trouble maintaining their heart rate. They could have trouble maintaining their digestion. They could have light sensitivity as they have difficulty with their pupils changing to light. It could actually start to push that vagus nerve against the jaw or the styloid process through here. And that physical compression of the vagus nerve is the same thing. It's going to take away the vagus part of the teeter-totter and put them into that higher sympathetic tone by removing the vagus activity.
Welcome, everyone, to a new episode of the Expect Miracles podcast. Today's episode is sponsored by uccnearme.com. Find an upper cervical chiropractor near you on uccnearme.com. Today, we have one of my favorite guests. He's been on the podcast. This is his third time. Me and Dr. Silver were just talking about this. His episode from 5 or 6 years ago is one of the most popular episodes to date on the podcast. There is nobody better that explains upper cervical care, neurology, and the connection, everything in between. It's always an honor to have him on the podcast. And without further ado, please welcome Dr. Josh Silver.
Thank you for having me, man. It's a pleasure, honor to be back again.
I love having you on, Josh. I always get so excited because I do believe that you are the best person in the upper cervical world that really explains the connection with the neurology, the brain, the craniocervical junction, and everything in between. And you put it in a really great perspective, not only for the doctors, but for the patients that are suffering with these conditions. And it's always amazing to have you on and speak with you.
It's been my joy, when the number one question patients ever have is, what's going on with me? How did I get here? And so just knowing kind of how the mechanisms of that misalignment play into the neurology of our brain helps me understand why it's doing this to them, why they're getting better. And just building that context on the case is huge for me and for the patient.
Dr. Josh, why, out of all the different upper cervical, after all the different chiropractic techniques and different avenues you can go down, why upper cervical? Why did you land on upper cervical, and why do you practice it today?
Yeah, I mean, when I was in chiropractic school, God, 15 years ago, I was interested in taking care of complex cases, like neck pain, back pain, okay, whatever. I wanted to see MS. I wanted to see Parkinson's. I wanted to help these tough cases. And consistently, the group that I heard these stories of success from came from the upper cervical group. So I started going to the club and hearing more of these speakers, and everything about it just kind of made sense to me, like not just feeling the misalignment and then taking kind of an educated guess of where it is, but really x-raying it and measuring it and knowing for a fact that it's shifted to the right and it's forward. Taking the guesswork out of their upper neck, that really appealed to me because if you adjust on the wrong side, you could potentially make the patient worse. And that's my worst fear as a
Mm-hmm.
doctor, is to ever hurt anybody. And so that was
Mm-hmm.
something that made a lot of sense to me about just the diagnosis of upper cervical, but also the treatment of it. Instead of me just grabbing that atlas and whipping it as hard as I can and praying for a pop, it just doesn't seem very medical, very safe. And I grew up in a classic
Mm-hmm.
Newtonian medical model, with upper
Mm-hmm.
cervical. It's not about popping. It's about being as precise as we can at the right place at the right time. And to me, that's more specific, and I feel more confident, more comfortable delivering those treatments.
What makes an upper cervical adjustment so powerful and able to help these people heal from all of these complex neurological cases?
Yeah, I mean, it's got nothing to do with the adjustment and everything to do with the problem that the misalignment causes. And just to see one bone sitting right underneath our skull You've got some major arteries going through there. You have some major spinal cord and vagus nerve and glossopharyngeal nerve, and just the density of the anatomy in that region makes these misalignments a potential source of so many different health conditions. And if we can adequately and proficiently fix it long term, then we're going to expect long term results with those types of things that are coming from that. So I just want to do the best job I can at correcting this most important area as completely as I can and as long term as I can. And that's all the things upper cervical care has to offer.
I love it. And this is a good segue too, because I don't know if upper cervical has done a better job over the last 10 years at making the connection with the vagus nerve and the autonomic nervous system. And I guess you could say there's been a rise of cases with dizziness, migraines, gut issues, tinnitus, weird neurological things that a lot of people are seeking upper cervical care for. And I actually had one person said, I wish you could have somebody on the podcast that could just go over the vagus
Yeah.
nerve, dysautonomia. And I was like, I know the perfect person to do that. And so, my first question, I guess, is do you think there is a rise in these cases over the last 4 or 5 years? Or do you think it's just there's been more of an identifiable connection with what's going on from the brain to the rest of the body?
No, I don't think diagnosis has dramatically improved of these. I think that there is an epidemic of more of these types of cases. And and they kind of blame it on two things. They blame it on COVID and they blame it on the COVID shot. I think
Hmm.
that for both of those, people that had either pre-existing conditions or they had problems years in the past that they had recovered from. Both of those, through inflammation, through the spike protein, whichever way you acquire that, seems to have brought back some of these older injuries or brought them more to the surface. And so I don't think misalignments are becoming more common. I think there's always been the same. I just think that people are becoming more vulnerable now that they have this extra inflammatory punch to it, so to speak.
I agree. And what is it about what for those wondering, what is dysautonomia and why is the vagus nerve so important?
Awesome. So we have two types of nervous system, so to speak. We have what's called the sympathetic nervous system, which is your fight or flight system. You see a bear in the room with you, your body goes full sympathetic. We got to run away from the bear. So your pupils get larger, your blood flow goes more to your extremities, your heart rate goes up, your breathing goes up. And it's the opposite of the parasympathetic system, which is we call it the rest and digest system. It's everything you do when you're not running away from a bear. So you're going to relax. You're going to move blood internal so you can do digestion. You're going to slow your heart rate down. You're going to slow your breathing down. And that parasympathetic nervous system is governed by this vagus nerve. Vagus nerve is a nerve, it comes out of your medulla, your lower part of your brainstem. And they call it the vagus nerve because it's vagabond means wander in Latin. And this vagus nerve wanders around our chest, our guts, and it provides this parasympathetic activity to all of our organs. And so people need to have a good balance of sympathetic to parasympathetic in their life. And both of these systems at different times are going to be turning on and off and on and off. And dysautonomia is kind of an umbrella term for dysfunction in the balance between these two systems. And so patients with dysautonomia, they're going to have trouble maintaining their heart rate. They could have trouble maintaining their digestion. They could have light sensitivity as they have difficulty with their pupils changing to light. And so there's many different types of dysautonomia, and we generally think it's either a problem with the vagus nerve causing it, or it could be too much of that sympathetic nervous system just on overdrive because the two of them act on a teeter-totter. When one goes up, the other goes down, and we don't wanna live on a tilted teeter-totter, we want a balanced teeter-totter.
And what causes people, so to speak, to get stuck in a fight or flight sympathetic response and they just can't turn on that parasympathetic response to rest and relax and decrease the cortisol and stress hormones in the body?
Yeah, and then a lot of the times you'll see that with trauma, right? So abuse survivors, they're in that abuse place, their brain goes into that fight or flight, gotta run away from the danger. And then they may years and years and years and years later, their body still perceives that threat. It's still ready to fight, run. And these people could have horrible digestive issues. They could have heart rate that's just beating out of their chest, really coming from a past emotional trauma. But that's what I think is
Mhm.
the biggest thing that raises that sympathetic activity. But pain can make us more sympathetic. When you ever hear like the pain that knocked the wind out of you, is that right? When we have pain, we become sympathetic. We got to run away from that pain. And sometimes chronic pain can also lead people to a state of that hyper sympathetic activity.
And does it correlate? How does an atlas misalignment correlate into all this?
So, an Atlas misalignment isn't going to have much to do with the emotional trauma, in my opinion. It could cause a lot of neck pain, and that could put somebody into a state of sympathetic. But more so, the atlas can affect the or the vagus nerve. The atlas has a bad role to play on the vagus nerve. And we have two main theories on why. One could be a direct compression of it. Vagus nerve leaves that brainstem and it runs right in front of that atlas. And if the atlas is rotated, it could actually start to push that vagus nerve against the jaw or the styloid process through here. And that physical compression of the vagus nerve is the same thing. It's going to take away the vagus part of the teeter totter and put them into that higher sympathetic tone by removing the vagus activity. And so that's something we think probably is occurring. And when we do an adjustment, we're physically moving the atlas away from it, making more room for that vagus nerve to travel. But the bigger theory is that our vagus nerve is going to control blood flow in our body. And part of our blood flow is going to depend on the position we're in, right? If I'm here, I'm going to need to push a lot of blood up to my brain. But if I was upside down, it'd be the opposite. I need to move blood towards my feet. And if that blood flow becomes imbalanced, then there can be symptoms in the tissues. And so the theory that's kind of leading in upper cervical neurology is that as we shift to the side, blood starts to pool that way. And it's part of the job of the atlas and the receptors around it to tell our brain what position our neck is in. And so if the C1 is misaligned to the left, then the brain starts getting signals from those muscles that we're tilted all the way over here. And what it's going to do is it's going to start to signal the vagus nerve to move blood to the left half of our brain. But if we're
Mhm.
actually upright and all the blood's on the left half of our brain, there's not enough blood flow on the right side of the brain, and that can cause neurological issues. And so we think that some of this vagus nerve activity is in relationship to the atlas. We adjust people with POTS and their symptoms get better. How is that possible? I think it's because we're changing the way the brain views its relationship to gravity. And blood flow from the vagus nerve is dependent upon where we think we are in a gravitational field. And we have great changes with that by restoring their relationship to gravity, by literally getting their head on straight. And I think that's a big part of
Yes.
the changes we see in POTS.
What are your thoughts on craniocervical instability, EDS, Ehlers-Danlos syndrome, where there's excessive motion in the upper neck? How do you feel upper cervical helps or can help with this?
So years ago, I found a lot of Ehlers-Danlos patients were finding me online, whether it was through the blogs, they'd been reading Upper Cervical is helpful. And so I did a deep dive into Ehlers-Danlos. And Ehlers-Danlos is kind of a genetic condition where the patients have stretchy ligaments. And what happens is if the ligaments become too stretchy in the upper neck, then that's going to contribute to the dysautonomia. They're going to have more rotation. It's going to be easier for it to rotate, or the joints are going to be sliding more than they should, and the brain's going to have less awareness of where it is on top of the spine. And so these patients tend to get POTS. POTS goes with Ehlers-Danlos
Mm.
probably through this upper cervical instability model where it's just not holding it correctly. And, the whole spine from C3 down is really designed for like stability and protection of the spinal cord. But for us to be able to turn our head and look out over the tall grass as our ancestors, we need to have all this motion at the C1, C2 joint. And so with Ehlers-Danlos, when you add extra movement to an area of the spine that's already very movable, A, that can create a big problem. But B, if we take a classic manipulative approach, it may make sense to manipulate and mobilize segments below C3 that get stuck, but these segments rarely get stuck. And when we crack them, we increase motion to a hypermobile area. That's not so good for those hypermobile patients. That's why upper cervical is so good for it, is it really helps it to get it back in the proper position. And by keeping in there, it can actually start to stabilize and heal some of those elastic ligaments. And I can't tell you how many patients with hypermobility I've helped in the last 11 years of practice.
With the hypermobility, what do you like to tell patients about the healing process? Because we do know that the ligaments usually take the longest to heal. What is your experience with healing the ligaments in the upper cervical spine?
So, with my systems at my clinic, I'm getting down to a point where about 80% of my patients hold their first adjustment for 30 days. I tell my
Amazing.
Ehlers-Danlos patients, do not expect that. We may need to do 4 or
Mm.
5 adjustments on you to get this to be in the right position, because that hypermobility creates more movement. But a trick I learned years ago is that distilled aloe as a supplement can
Mm.
actually stimulate these fibroblasts, which are the cells that lay collagen into ligaments. And when you give a hypermobile patient a shot glass a day of aloe, it kind of stabilizes their ligament structure. It helps them hold a little bit better. And so all of my hypermobile patients, that's a day one recommendation that we make. And I mean, day 7, day 10, are you still taking your aloe? Are you still taking your aloe? This is going to work a lot quicker, a lot faster for you if you can rebuild some of those ligaments.
Is there a certain product that you recommend? Because I know if you go to Whole Foods, there's probably 10 or 12 products. Is there one that you find, that you recommend more than others?
There's like George's distilled aloe. George's company, they make a lot of organic good stuff. So that's generally what I go to, and you can get on Amazon for like $30 for the gallon. I've probably
Wow.
put 200 patients on aloe in my career now.
And you notice a huge difference with the holding on the aloe.
And it's not just that they're holding better. They'll be like, "Hey, since I've been taking that aloe, like my left elbow clicking has gotten better.
Wow.
My right ankle instability seems to be doing better." It hits all their ligaments, and that can just be really important for those patients.
Amazing. And Dr. Silver, we're kind of touching on everything here. One of the most prevalent cases upper cervical doctors are seeing now is dizziness. Now, how does upper cervical misalignments correlate with dizziness and some types of other vestibular issues?
Good question. When we say the word vestibular, most people are thinking about these receptors in our inner ear. And anytime we move our head in space, fluid moves in those inner ears, and it turns on neurons that end up sending signals to our brain that, hey, you're turning left. Hey, you're moving forward. Hey, you're moving back. It's where we get a perception of motion. But the vestibular receptors send their information to the brainstem, to a cluster of neurons that we call the vestibular nuclei. And those vestibular nuclei are responsible for building a picture for your brain of, where am I in space? Am I straight up and down? Am I tilted to the right? Am I tilted forward? Am I tilted back? And that vestibular system in your ear is only one third of the input going into that brainstem. The other one third we're going to get is from our visual information. So I'm saying, can patients track? Can patients converge? Can patients jump their eyes? Because if you see the whole world tilting visually, you start to tilt your body, right? You ever been in one of those tubes where it's spinning, you start to
Mm.
fall over
Yeah,
just
yeah,
from
yeah.
visual information. And a lot of patients will come in and they'll be like, man, my vision makes me dizzy. Like when I'm in a Target, there's a lot of stuff going on. My vision makes me dizzy. So vision is one third of the puzzle. Your inner ears are a third of the puzzle, but your neck is one third of the input to that central vestibular center. And when I tilt my head to the right, we want the right ear to say that I'm tilted right. We want the muscles in the neck to shorten and that to send a signal to my brain that I'm tilted to the right. And then the whole world starts to tilt, and that visual information tells you you're tilted to the right. And when the ear information, the eye information, and the neck information are all kind of singing the same tune, then patients don't feel dizzy. But when people have been in different types of accidents, they may get a misalignment in their neck, and that misalignment is telling their brain that they're tilted to the right. But then their eyes have an issue, and they see everything is shifted left, the opposite way. And they may have an inner ear condition where they're not picking up left rotation motion correctly. And so it's really in these scenarios where the eyes and the ears and the neck are all sending these different signals to the brain that the brain starts to feel dizzy. And so,
Very
you know, if the
interesting.
neck is I'm sorry, if the eyes are healthy and the inner ears are healthy, it's possible that a neck rotation could cause dizziness. We call that
Mm.
cervicogenic dizziness, dizziness coming from the neck. And it's a pretty well acknowledged diagnosis in medicine. There's an ICD-10 code for it when I'm coding. And a lot of these patients are going to have their dizziness improved with upper cervical care.
Amazing. And Josh, I would love to ask you about the pathology for strictly tinnitus. So I have patients with tinnitus, dizziness, migraines. Those people do really well. When somebody comes in and say, I just have tinnitus, I kind of stop. And so sometimes we get it to reduce or go away. Other times the neck adjustment is just not touching it. What is the pathology for tinnitus, and when do you see it's more coming from the neck rather than other areas?
Absolutely. Yeah, I just had a case last week. He had pulsatile tinnitus. So he hears
Hmm.
thump, 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 thump. And we did his first Atlas adjustment and that improved 90%. You know,
Hmm.
so we can expect that type of patient's tinnitus to improve when we know that it's what we call somatic tinnitus. Somatic generally means tinnitus from your body. And so it's more likely that with him, the rotation of his atlas was straining the vertebral artery. And that was creating this reverberation of the pulse up into the ear. And when we adjusted and we opened that up, that's something that when I hear pulsatile tinnitus, oh, I get so excited.
I
Usually
love pulsatile tinnitus.
I think we're
One of
gonna
my
do pretty good
favorites.
with pulsatile tinnitus. If it's just a ringing in their ear, I
Mm,
ask, "Oh, do you hear it in one ear or do you hear it in both ears?" Because typically when it's somatic tinnitus, there could be a tightness in the neck, there could be a tightness in the jaw, and that can kinda tense that eardrum, and that can affect the way they're hearing or they're affecting that. And sometimes we do really, really good with those types of tinnituses. Sometimes we don't because it's not the neck, it's more the jaw or it's inner ear pathology. So if they have not pulsatile tinnitus, but just like unilateral buzzing, I say I expect about a 50 to 60% chances of us helping it. However, if it is central tinnitus, tinnitus where they hear it in both ears, usually it's coming from their temporal lobe in their brain. And this is a part of the brain that recognizes hearing. And you have different neurons that are going to recognize different pitches. And if a certain one of those neurons for a certain pitch becomes injured, then it's going to start to discharge for no reason. And the patient is going to perceive that sound, but like in their head. And on central tinnitus, both ears, history of head trauma, but not always. I don't expect the adjustment to really make a change on that so much. But what's interesting is that in functional neurology, maybe we can stimulate that temporal lobe other ways. And the temporal lobe processes smells. And so
Mm,
sometimes I'll actually go more towards aromatherapy in central tinnitus.
really?
And we can
That's so
sometimes find
interesting.
the lavender, actually. I don't know why lavender specifically works pretty well on stimulating that temporal lobe. And that's going to be more my attack plan for central tinnitus.
And what's the frequency of that aromatherapy
I'll give it to them every day,
usually?
you know? I'll say,
Yeah,
"Put a little bit on your shirt and just walk around with that every day and
that
let me
is
know."
so interesting.
Yeah.
Wow. And Dr. Silver, what really gets you up in the morning? What are some of your favorite cases to see in your personal clinic?
You know, I did a back handspring on my head when I was 10, and I pretty much suffered headaches for 12 years after that until I learned about upper cervical care. And so just being a chronic headache, survivor, I get so excited when I meet young people my age with chronic headaches.
Mhm.
Because whether it's, a cervicogenic headache or a migraine or a tension headache, we tend to do really good with all of those in my practice. And, I just had another guy. He's a man who probably in his 50s, he's been getting like 12 migraines a month for most of his life. And
Wow.
we've done 2 adjustments on him in 3 months, and he just went, 30 days. He had 2 headaches in 30 days, just remarkable progress for him.
Amazing.
So I'm very passionate about headaches. And there's a lot of things that contribute to headaches. Upper cervical is where I start on every case, but now with the neurology, there's so many doors we can go down that headaches can be like kind of a really fun problem solving experience for me. So I'm big on those. I'm huge
Very
on
cool.
concussion. I love treating concussion cases. Because in concussion, they're going to go from doctor to doctor, looking at their eyes, looking at their ears, looking at their face, looking at their brain, but they like never look at their neck. And it's
Mhm.
impossible to hit your head and get a concussion and not suffer a neck injury. And so very often I'm like one of the last stops for them. They've been everywhere else. And we just do such good work sometimes in, very quickly with the upper cervical approach. I love treating concussions and it sometimes just makes you look like a hero.
I love that.
Yeah, we do a little dizziness at my clinic, and we can't, we do vestibular rehab, we'll do eye motions, exercises, but step one is always the atlas adjustment on those cases.
Very nice. And I believe my associate, Dr. Jeff Scott in New Jersey, took one of your, what's a good way to put it? It's like functional neurology mixed in with the upper cervical work. Is there if there's upper cervical doctors listening to that and they want to see how you combine the functional neurology with the upper cervical, is there a place where they can, have access to that seminar?
Yeah, yeah. Well, let's just start with that. As an upper cervical doctor, I knew the eyes and the ears were important for them holding because sometimes a vestibular loss could lead to a persistent head tilt. And it's hard to adjust that, or they might not hold. And sometimes if they can't smoothly track with their eyes, and when they try to look to the left, since their eyes can't do it, they turn their head to look to the left, and that extra neck motion may destabilize their neck. So I spent 12 years in the functional neurology world trying to learn how
Wow.
to fix those types of things. And then I simplified what's important into a course for upper cervical chiropractors to try to save them the 12 years and thousands of dollars of study
Yeah.
I did. So 2 years
Yeah.
ago, we hosted upper cervical neurology. It was a 2-day seminar specifically for upper cervical doctors. We had like 50 people there. It was an amazing event, and we ended up filming it, recording it, and putting it online. So
Very cool.
I believe the website is uppercervicalneurology.com, and they can get
Hmm.
the course there if they're interested. But I know
Amazing.
from my experience that when we started fixing these things after the adjustment, we'll check every patient for these dysfunctions. Not every patient has them, but on the patients that do have them, when we correct them, we expect longer holding times. And because it's helping them hold their adjustment, the functional neurology is very much chiropractic for me. It's very much helping me achieve my original goal of getting their atlas to hold properly.
Love that. Dr. Josh, we are running out of time here. At the end of every show, I like to ask all my guests, what is one piece of advice that has really resonated with you over the years that you would like to gift the audience? Could be absolutely anything.
That's a great question. If it was for the young upper cervical doctor, I just have to tell them stick with it. It is not easy to do this work, and you get better at it every adjustment you do. And, the results I'm getting now, 11 years in practice, I fantasized about them for
Mm,
5 years. And so stick
hmm.
with it. Trust the systems. They've been in place for 80 years and they work.
Mm,
But I'm also very much don't be afraid to think outside the box. We set some certain rules for how to do this work back in the 80s. And now that we have 3D imaging, we have so much more data that it's okay to break the rules. And that's how we create new innovations in healthcare, is by challenging old norms. And so be inventive, be creative, and keep pushing for what the best treatment is for your patients because we'll never be enough in this profession. Patients will always need more out of us. And that's why we always have to be continuing to improve ourselves. And hopefully, by me being the bestest, healthiest version of myself, I can provide the bestest version of quality of care for my patients.
I love that. And Dr. Silver, where can people find you on social media and book appointments with you online? Where can they do that?
Yeah, so my website is neurostpete.com, neurostpete.com. I have a lot of free resources for chiropractors. My Instagram is Dr. Josh Silver. I've got about 100 videos up there now of me doing different neurology techniques. And then I also have a website, advoaccessories.com, where I sell products for chiropractors that I've invented. I have the seminars listed on there as well. All of those are great ways to reach me.
Amazing. Dr. Josh, thank you so much for coming on. Like I said before, one of my favorite guests on the podcast, and I would really love to do this again sometime soon.
I hope we do.